All right, I got nothing to disclose. This is a case of an 80-year-old man who presented with chest pain to one of our attendings' office, CCS class 4 for 2 weeks. He has a history of CAD, multiple stents to the LAD, 2 in 2005 and 1 in about 7 months before his presentation. Had a TAVR with a 26 millimeter S3 valve 6 months prior to presentation. And his post-TAVR gradients were 7 millimeters. COPD, hypertension, hyperlipidemia, prior CVA, and no residual deficits. So this was his presenting EKG, right bundle branch, left anterior fascicular. It was normal sinus, normal heart rate. So these are films from his TAVR was done at an outside hospital. And you can see the first image on the left is the valves being deployed, and then the image on your right is post-deployment angiography shot. Not very great, but you can see that the left system is pretty open. So our workup included a limited TTE, which showed an EF of 40 to 45%, no significant wall motion abnormalities, and the aortic bioprocess was not well visualized. The right heart cath, pretty normal pressures. Left heart cath gradient across the valve was 13 millimeters, and the valve area was 2.3 centimeters squared. This is the diagnostic cath. So you can see ostial left main disease, pretty obvious. And then in the left cusp, you can see some tissue just kind of compressing the ostium of the left main. So the LAO caudal view, the spider view shows this better. You can see the left main's almost 80% occluded at the ostial level. The stents in the LAD are patent. He also has other disease, OM2, 100% occluded, and the first diag is 80% stenosed, but he had this disease prior. So this is the right with minimal luminal irregularities. So at this point, our differential diagnosis was coronary artery disease, which you can see seems less likely. He did not have any disease prior to his TAVR, and 6 months, maybe too short a time to develop that unless it was an ACS. So it could be thrombus, could be dissection, but again, this is almost 6 months out and less likely, and he was taking his antiplatelet regimen pretty regularly. And the other differential was a native valve tissue compressing on the ostium of the left main. So we thought this was the most plausible etiology. So we took him off the table, had a heart team discussion, and he was considered high risk for CABG. So the plan was for left main intervention. So the next question in our minds was whether we need to use mechanical support up front or not. And if we did not use, do we get access? And if we did get access for an impella, should we cross the valve or not? So given that his EF was 40-45%, it was stable angina, and there was no significant right-sided disease, we decided we would not put an impella up front, but we did get contralateral access. And we crossed the valve and placed a pigtail. So these are his iliacs, good sized, pre-tortuous. And so we put in a 14 French sheath in his left femoral artery, used an R4 straight glide wire, crossed the valve, and switched it out for a pigtail in the LV. So if we needed, we could just put in an impella quickly. On the right side, we got an 8 French access, and went ahead with a JL5 guide, and we wired it with a BMW wire. It wasn't easy. We had to use a microcatheter. We used a Turnpike LP, but we did finally wire it. And after wiring, just for good support, we pulled out the BMW and switched it out for a wiggle wire. And we started off initially with a NC Quantum 3x15. This is the IVUS run after the initial 3x15 balloon, and you can see the cross-sectional area is only about 5.8, not really well expanded. So we used next size 4x15 balloon and dilated it again. And so at this point, we decided to stent, and the question was, which stent do we use? Because we wanted a stent that would give us good radial support and not compress from pressure from this tissue that's the native valve tissue. So I just have, it's interesting, two screenshots here of radial strengths of various stents. On this, you see Synergy stent seems to have the highest radial strength, followed by Xience or Zero, and then Resolute Integrity, whereas on this, Resolute Onyx has the higher one, and Resolute Integrity, Promise, and Xience seems to be at the bottom. But anyway, we decided to go ahead with the Xience, and we used a 4x28 stent. And you can see after the stent was placed, the ostial left main is still not very well expanded, and the tissue seems to be compressing. There's some compression still present, and we thought that this radial strength may not be sufficient. But anyway, we IVUSed, and you can see it's still not well expanded. So we went ahead and post-dilated with a 5x15 NC quantum. And we still were not satisfied. So at this point, we had a discussion and decided that we need a second stent. But before that, this is the IVUS run. The cross-sectional area was good, but it's still some compression from that tissue. So the second Xience was a 4x15, and we post-dilate with an NC Trek 5x15. And then I'll show you the final result in 1 second here. This is the final IVUS run with a cross-sectional area of 15.8. Much better, though still there's some compression, but. And then these are the final angiographic shots. And so we had to put the stent, extend the stent outside the ostium. That's what's been suggested by prior case reports and studies to prevent the radial compression by the tissue. So he did well, no symptoms after this.
It's a good case. Good that we use the Edward Sapien, but if it be like core valve, then it would be nightmare, first of all. And finally, it is a very good result. But do you think that is there any AI when you deployed the Sapien valve before? There was some space in between, but look like it's a perfect place. Like the orientation of the it's like 80-20 or maybe 90-10. It was not. What was the height? When you deployed, I don't really remember or not, or from
You're asking of the coronary height or the valve?
No, coronary from like the coronary height, like 14, 8, 10.
Oh, it was around 12, but this
12.
was done at an outside hospital, so it wasn't our
outside.
measurements, it was from outside.
Okay, probably that's. You have any other question?
I'm just wondering, it sounds like this coronary intervention took place about 6 months after the valve was placed, is that
Correct. Yeah, the tower was 6 months prior.
Did you have any follow-up CT imaging of the valve that gave you information about that?
No.
Placement of the native valve tissue?
No, there was this angiography shot after the valve was placed, and it was at an outside, and that clearly showed there was filling of the left main. And his symptoms started 3 to 4 months after the valve was placed, and it was progressively getting worse.
Yeah, it's undoubtedly you have the right diagnosis. I have to admit, I thought that was a dissection when you showed the first injection, and I was, again, getting sweaty. I'm sweating a lot.
How often do we see this, Poonam?
It's not very common. There was a recent paper in JACC, I believe, out of 18 centers, they had 17,000 patients, and it was 0.2%. So it's not very common, and especially the late delayed are much, much lower.
Are you doing anything different with his antiplatelet therapy now that you have double layer stent in the left main with a prolapsed valve there as well?
Aspirin,
and also
ticagrelor.
something there around the valve that may
Yeah.
serve as a nidus for clot formation.
Correct.
Are you doing anything different?
Yeah, we weren't doing anticoagulation because we know this is valve tissue. We just did a dual antiplatelet therapy.
Question, yes, sir.
Do you modify such stents after the procedure? Because I don't know how will you get in the next time if there's something wrong with the patient.
So from the prior case reports and that paper, they say the stent has to extend beyond the ostium. We really don't use much of an osteal flash because you want that stent to stay open and prevent the radial compression. So I guess you have to work around and just try and engage it. You have about millimeter or 2 millimeter stent protruding outside. So we have to work around and just kind of engage it.
If I'm not wrong, did you say that you prefer ticagrelor than Plavix and than clopidogrel, and that's why? What was the reason?
Sorry, say that
I
again.
think that you said that you used the double blended therapy with aspirin and ticagrelor. Is this correct?
Correct.
And why did you prefer ticagrelor instead of clopidogrel, let's say?
Just because there's 2 layers of stent, and ticagrelor has a higher
Maybe because it was also left main?
left main.
Great.
Well, thank you very much. Really
Thanks.
terrific case.
Thank you.